Lovely. Thank you, Nicole, for that introduction, and a big thank you to the East Melbourne PHN for arranging tonight's presentation. So as Nicole said, my name is Beck, and I'll be starting us off this evening. You'll hear from my colleagues, Dr. Juliette Gentle and Anton Harms throughout as well. So tonight we'll provide a brief introduction to osteoarthritis in the context of highlighting the importance of exploring non-surgical pathways. We'll discuss the new statewide criteria and essential information to include in referrals to specialist clinics. We'll outline what best practice conservative management for hip and knee osteoarthritis should include, with a case study to highlight key features. We'll then outline some resources for effective non-surgical management, identify services available for referrals in the community, and also Northern Health's Musculoskeletal Wellness Osteoarthritis Program. Finally, we'll leave you with what we hope is some useful messaging to help with patient expectations, adoption, and adherence. There we go. As we all know, the burden of osteoarthritis in Australia is unsustainable. It's a chronic consequence of ageing and affects 1 in 10 Australians. It's the most common lifestyle disease in people over 65 years of age. It's predicted that healthcare costs of osteoarthritis are set to reach $3 billion by 2030, and it's one of the most common reasons people in Australia see their GP. Current clinical guidelines recommend non-surgical treatment such as education, exercise, and weight management as the first line of treatment for people with osteoarthritis. However, only 4% of people diagnosed with osteoarthritis are referred for non-surgical management. Patients instead endure long wait times, waiting to be seen by orthopaedics. Currently in Victoria, the average wait for non-urgent patients is 2.1 years for initial appointment. With this in mind, the Department of Health have released new statewide referral criteria, and I'll hand over to Juliette to go through it.
You're just on mute, Juliette.
I did press the unmute, at least I tried. Anyway, sorry about that. Now can you see my new statewide referral criteria slide?
No, your screen isn't sharing just at this moment.
I'll try again. Desktop. And now it says participants can see my screen.
Yep, but we can see your desktop.
Yep.
Now we can see your slide.
Perfect. Lovely. Thank you. It worked better than last time I did this anyway. So thank you, everybody, and thank you for the introduction and background from Beck. So what I'm presenting this evening is really a summary of the Department of Health's new statewide referral criteria, how they were developed, but particularly looking at hip and knee osteoarthritis, and to kind of put those in context for Northern Health and the topic we're going to be talking about a bit later, which is non-operative care for patients with hip and knee osteoarthritis. So the new referral criteria for specialist clinic referrals, why did the Department of Health develop them? Because people have been referring to specialist clinics, GPs have been referring for a very long time. So the goals are basically to assist GPs and clinicians who refer patients to specialist clinics, to improve access by improving the quality, and I've kind of highlighted consistency there because the referrals that are received, there's a lot of inconsistency even within our hospital, and also the appropriateness of referrals. It helps to assess and appropriately triage the referrals to get patients an appointment in the most appropriate time frame, and also to provide guidance for seeking further information. The referrals will be assessed against the same criteria in all Victorian public hospitals, and the clinicians within hospitals who process referrals will also have access to the same information, so there's less variability amongst clinicians when they're referring, if they're triaging different, I guess, referrals with different level of detail. Referring clinicians will know when a referral to a public specialist clinic is required, and also the information that should be included. The last goal is that the Department of Health wanted to improve referral and communication processes between referrers and clinic services. So really, to summarise that, is that it's better for patients because access to specialist clinics will be improved. So how were they developed? It was quite an involved process. So this is not something the Department of Health has said, we must now do this. It's actually been a very collaborative process. I was involved in the hip and the knee osteoarthritis criteria. However, there's been a lot more, which I'll touch on in a moment. How were they developed? A clinical review panel for each condition, which was chaired by an independent public health service executive, were convened. There were several online meetings for each condition, and in between meetings, the discussions and the information was reviewed and refined in between. The panel membership was multidisciplinary, so the list of people who were involved are listed there. So for obviously orthopaedics or orthopaedic surgeons, general practitioners, allied health and nursing staff, GP and primary care, and primary health network clinical writers. And the criteria developed were the final consensus of the panel. So implementation of referral criteria has actually occurred in a number of specialties already. This is about a third of the list that you can find on the Department of Health website. But just for brevity, I've just added a few of the specialties there. Those that have been in use were evaluated during 22 and 23 and showed that the key evaluation findings had the referral criteria had the intended outcomes, which in a nutshell were to show a downward trend in the total number of referrals received and an overall improvement in the quality of referrals. So these are a few that will be coming up have been revised or will be for implementation in 23. Some of them are running a little bit late, but 24, early 2024, really, I'm not sure if they're released now or about to be, but the osteoarthritis of knee and osteoarthritis of the hip will be in use. And there's other musculoskeletal conditions which also will be released and staged release over the next few years. So in a nutshell, I'm going to run through the knee criteria, the information needed, and the hip criteria, the information needed. And just to preface that by saying the huge range of referrals that we receive really range from excellent referrals, which already include a lot of this information, to very brief referrals, which doesn't give you a picture of the condition, the patient, and the circumstances around the requirement for the referral. There was also a very strong view of the clinical panels when these were being developed, and I've just popped in green there. So to refer for a patient who has osteoarthritis of the knee, the patient must have identified osteoarthritis of the knee with ongoing moderate or severe pain and/or functional impairment, despite at least 3 months of treatment that has included target education, physiotherapy, and weight loss where appropriate. Now, we'll talk about this a little bit further, but that's the gold standard for early osteoarthritis treatment, is to try non-operative modalities first. Occasionally, I shouldn't say occasionally, quite often we've been seeing referrals, or we've been seeing patients in clinics, and I'm sure this happens everywhere, who've had a diagnosis of osteoarthritis in the community, have been referred to an outpatient clinic, and during the sometimes 1 or 2 years wait, haven't been doing physiotherapy, and during this time, their condition deteriorates, they can defunction, and their symptoms can worsen. So we really want to get on top of that early in the referral process. So information that must be included in the referral. And again, this is all a summary from the Department of Health website. The reason for referral, the expected outcome, anticipated the patient or the carer or the referring clinician. Physical examination findings are really helpful. The onset, nature, and I've underlined duration of symptoms. That makes a big difference to know how long the patient being referred has had their symptoms for. The impact of their osteoarthritis, it may include days off work, inability to care for a relative because of their osteoarthritis, or perhaps lack of sleep because of their symptoms. Also, details of previous management, which ties into the underlined green section, but also medical therapies, anti-inflammatories, etc., other courses of treatments and the outcomes of these treatments. So they may have tried a brace, they may have had injections, all that's really useful to have included. The consensus of the group, it took a while to come to a consensus as to what x-rays patients did require, but it was decided that the best imaging to have available were 4 views of the affected knee, which include a weight-bearing antero-posterior, a notch view lateral, and a skyline view. And just a note, ultrasound imaging is not indicated and MRI scans are not required if osteoarthritis is shown on the x-ray. The HIP criteria, I'll just really flash that up there because it's the same types of things. What are the symptoms like? Physical examination findings, impact on the patient. And the x-rays required for a hip are AP of the pelvis with the hip showing a proximal 2/3 of the femur, and a lateral view of the affected hip, including weight-bearing and standing views. So all that information must be included. Information which is useful to have if it is available include details of previous surgery, results from hip or knee questionnaires. We know this can be quite time consuming, so it's not essential, but if it's something that you do in your GP practice routinely or have been considering doing, then a hip or a knee questionnaire can be really helpful. Currently, these are obviously these are often or almost always included in referrals. Complete medical history, any medications being taken, but also again underlined if there can be a statement about the patient's interest in having surgical treatment. If that's a possible intervention, it's really helpful as well. And identification as an Aboriginal and Torres Strait Islander, or if the person is part of a vulnerable population. That helps triaging. It also helps to collect data and help to direct services appropriately. So I've popped, it's really just repeating the underlined green, the new statewide criteria. I think the most important thing for osteoarthritis of the hip and knee is that referral to a public hospital is not appropriate, where at least 3 months of treatment that includes targeted education, physiotherapy, and weight loss where appropriate has not been trialled. Now, I'm going to hand over to Beck and Anton to talk about that, but please just be aware, we're absolutely aware that access to non-operative care for patients can be difficult. Physiotherapy services in the community may not be available, and coordinating things such as education and dietetics, it can all get a bit hard and a bit complex. So we've tried to do something about that. I'll stop sharing now and hand back to Beck and Anton.
Okay, thank you, Juliette. Oh, have I?
Yep, you're perfect.
I'm perfect. Okay, great. Thank you. So often patients come into our clinics and report having tried physiotherapy or other non-surgical interventions before. But when we ask follow-up questions, they've often said that they've had massage or electrotherapy, or they've been to the gym once or twice, but they've not used any weights or had any progressive loading. And they don't really understand the significant role conservative management has with the treatment of osteoarthritis. Clinical guidelines support a stepped approach to care where core non-surgical interventions should be offered to everyone, irrespective of the stage of disease, that being education, exercise, and as indicated, weight control. Osteoarthritis can be diagnosed clinically without the need for imaging. Plain X-rays may be required for ongoing moderate or severe pain and/or functional impairment, and MRIs are typically only indicated if a differential diagnosis is required. So what does effective non-surgical interventions or conservative management look like? It should aim to reduce patients' symptoms, improve their function, and improve their quality of life. It should include a comprehensive assessment of the whole body and not just the arthritic joint, so that all contributing factors are identified. These could be fear of damage or lack of confidence, stress, anxiety, diet, muscle strength, but also coordination and endurance. Are the muscles working in a synergistic way, or are the soft tissues tight or stiff? The location of the pain is not always a reliable guide to where the pain is coming from. Assessment and treatment must be directed to the source of the pain, not necessarily where the patient feels the pain. Balance systems could be explored, as well as sleep habits and hygiene. Conservative management needs to be tailored to the individual patient and consider their comorbidities, socioeconomic factors, as well as their function and goals. Management should not be limited to exercise therapy, and it needs to be holistic. Diet advice and education is just as important as physiotherapy. Behaviour change coaching and orthotics could be considered as well. Importantly, it takes time and persistence. Doing a couple of exercises for a few days or even a week or two is not going to be helpful. It takes time and repetition for muscles to get stronger and for a change to occur. These are the kinds of goals that your patients should be reporting on when they review with yourselves. Things like reduced pain and reduced reliance on analgesia, reduced days off and sick leave from work, feeling more confident and able to walk further. And if your patient is not progressing, you could ask them about what interventions they have received and are they mentioning any of the key features of effective conservative management.
Thank you, Rebecca. And I'm just going to share a very fascinating case study that came through our clinic over 10 years ago now. This 51-year-old lady was assessed in 2012, and she had really quite severe medial right knee pain. She was quite adamant, though, that she did not wish to pursue an orthopaedic surgical pathway. On assessing her strength using an open chain assessment paradigm with an ankle cuff weight, she was barely able to lift her heel from the plinth when I put a 1 kilogram ankle cuff weight on her ankle. So I went through an educational process informing her about the options with an exercise program, and I gave her an outline, an outline of a very basic progressive quadriceps strengthening program. You can see that there on the left side. She bought ankle cuff weights, and I arranged to see her 6 months later. We talk about finding the activity and exercise sweet zone. And this lady found her sweet zone, which is not too little, not too much, just the right amount of exercise for her and activity for her. This is a key feature of our education program. It's really important that patients work very closely with their physiotherapist to find their exercise and activity sweet zone. It's a two-way process. Not just, people often say, oh, I did the exercise, it made me worse, and that's all, and they give it away because they haven't negotiated sweet zone. So she came back 6 months later. She was lifting 5 kilograms. She had no pain, and I discharged her. She has returned to Northern Health several times since then for other reasons, but has not come back in regard to her knee. She came back once in regard to her knee, but she was discharged again.
Thank you, Anton. So the Musculoskeletal Wellness Program at Northern Health was created to address the growing orthopaedic demand, divert and delay arthroplasty as appropriate, and importantly, to offer timely, evidence-based, non-surgical management for patients with osteoarthritis in line with clinical guidelines. This program has been developed by the Orthopaedic Physiotherapy and Dietetics departments, alongside researchers and the Transcultural and Linguistic team at Northern Health over the past 5 years, with continuous iterations to refine the program. The first patients were enrolled on the 12th of October in 2022, which coincidentally aligns with World Arthritis Day. We have since screened over 1,100 patients from the outpatient waiting list, and half of whom have been discharged. The development of the program is evidence-based and guided by clinical experience, along with the Royal Australian College of General Practitioners guideline for the management of knee and hip osteoarthritis, the NOI Group's Knee Osteoarthritis Handbook, the Victorian Model of Care for Osteoarthritis of the Hip and Knee, my exercise program, developed by the Centre for Health, Exercise and Sports Medicine at the University of Melbourne, and the GLAD program, which is a good life for osteoarthritis from Denmark. Patients follow the web-based program in the convenience of their own home at their own pace. There is regular support via telehealth from experienced clinician, and that level of input varies between each patient depending on their need. Patients have been screened by an advanced practice physiotherapist with additional credentialing and upskilling in osteoarthritis. The website has been translated into Arabic, and we are currently developing Turkish content. We hope to include other languages in the future as well. All patients are invited to complete surveys to track their experience, progress, and symptoms. Those unwilling or unable to participate online are offered face-to-face group classes, and the group replicates the online exercise and education content. The website includes a structured 12-week exercise program incorporating strength, stretches, and balance exercises. All of these exercises have a recorded video for patients to follow. It's recommended that the patients complete the exercise program 2 to 3 times a week, alternating with a walking program. There are 4 levels for patients to progressively work through, and all patients have regular telehealth consults with physiotherapists to guide them and support them. There's also a structured 12-week dietetic program where patients progress through a variety of different topics. Diet can play a key role in reducing pain and inflammation, as well as improving a person's gut microbiome. Research suggests that in knee osteoarthritis, losing 10% of body weight has been shown to reduce pain by half. So as appropriate, weight loss management is also provided. The level of ongoing one-on-one dietetic input depends on each patient's needs. The education page includes information regarding the pathophysiology of osteoarthritis, potential causes, and treatment of OA. This content is targeted at the patient population. There's also a comprehensive resources page where patients and healthcare professionals have easy access to guidelines and further information about physical activity, nutrition, and the treatment of osteoarthritis. To date, emerging data states that at the end of the program, 64% of participants no longer want surgery due to pain, and 42% report themselves as better on the Global Rating of Change Index. We are seeing improvements in KOOS and WHO's functional scores, and over 95% of patients report the program to be little to no burden. We have a wide reach with participants from 20 different local government areas, suggesting that care closer to home can be convenient and well supported. Testimonials are really promising, with patients saying things like, "This is life-changing. Before I started doing the exercises, I was taking 6 to 8 Panadol a day, and now I don't take any." So in terms of accessing the Musculoskeletal Wellness Program at Northern Health, firstly, I think we need to acknowledge that the Musculoskeletal Wellness Program is relatively new, as is, of course, the Statewide Referral Criteria. So we are still working to establish the easiest and clearest way to refer to the Musculoskeletal Wellness Program. At the moment, we think the simplest way is to stratify your patients into 3 broad categories. The first are patients who you're seeing for the first time in regards to new pain or symptoms that clinically fit the picture of osteoarthritis. These patients are ideal and very suitable for a structured non-surgical intervention, either in the community or through the Musculoskeletal Wellness Program. The second group are patients who have attempted conservative management, but have returned to you and is not progressing as well as they or you would like. These patients potentially fit the orthopaedic criteria for a referral, but should be encouraged or recommended to partake in non-surgical intervention while they wait for orthopaedics. And the third group are patients who have severe symptoms, are extremely functionally limited, and require an orthopaedic appointment for surgical opinion. These patients should have already completed a comprehensive conservative program in the past that could be considered for the Musculoskeletal Wellness Program or similar as more of a prehab approach. The key here, as Juliette has mentioned, is to provide detailed quality information on the patient's referral in line with the statewide criteria. This allows us to direct the patients to the most appropriate service. So perhaps flagging on the referral if or how they may be suitable for the Musculoskeletal Wellness Program. We're in the process of expanding and developing a digital care pathway, which will improve our capacity. But it is important to note that as much as we welcome and are excited to receive referrals, we don't currently have the capacity to see everyone with osteoarthritis. So it's important to consider other community-based options before referring. And these could be, like, for example, the GLAD program developed by researchers in Denmark. This is a group-based education and exercise program. The program is available throughout Victoria at both community health centres and in private practice physiotherapy clinics. Some private physiotherapy clinics also run similar osteoarthritis programs in addition to the standard one-on-one clinical service. Melbourne University have developed a free online guide for knee osteoarthritis, which includes education and a home-based exercise program. However, this is entirely self-directed, so bear in mind that there's no clinician support. Dietitians can be found at community health centres, where often they can refer themselves. And accredited practicing dietitians can also be found on the Dietetics Australia website using the Find a Dietitian tool. Gyms, pools and walking groups are readily available through local councils and could be a useful adjunct to a structured management program. Remember, in patients over 65 years of age, they can only access community services with a Commonwealth Home Support Package, CHSP. This is completed via a referral through the My Aged Care portal and should take less than 10 minutes to complete. Patients could also be considered for a chronic disease management plan, which reduces financial burden, so may improve access. In the coming days, we'll send out a document via email, which summarises some local recommendations. Important to note, we have no financial or professional affiliations and simply recommend these as they value exercise-based therapy, appropriately progress patients and collect outcome measures. Also of note, there is a cost associated with community health centres, not just private clinics. The cost per visit depends on patients' income and varies considerably from around $10,000 to $150. Oh, sorry, $10 to $150.
I often assess people who say, I've got bone on bone. And that sounds terrible. And as you saw in the previous, in the case study, it doesn't necessarily matter. It may not, and very often when I look at the x-rays, they're not bone on bone. They're not, there is still some degree of chondral, of joint space there. There's chondral coverage. So what we say is really influential and really important. People have been told they need a knee replacement, and they end up not needing it. People have been told there's nothing that can be done. You need to go to the orthopaedic department. I've heard that people have said they've been told to stop walking, stop exercising because it'll wear out the knee. It's too far gone for exercise. Which is certainly not true. It's not purely a wear and tear disease. And using that term is a negative, gives negative vibes. Exercise and physical activity is medicine. Exercise nourishes the knee, and it being inactive increases our risk of so many chronic diseases. The knee is robust, it's not fragile. The knee I showed you is very robust. The cartilage needs appropriate loading to thrive. Movement and exercise will not damage the knee. So reinforcing these to your patients would be really very positive. Pain does not equal damage. We've talked about the weight previously. There are many things that can be done to slow down the progression symptom or even eliminate symptoms entirely for the rest of their lives. And that's about it. So thank you very much. And we'll be waiting for questions later on.
Yeah, I think we just,
Oh.
and then we can just stop sharing.
So
Just
stop sharing.
I think so. We'll just summarize.
Thank you for that. We'll just wait until Crystal. So that's it from you guys? Wonderful. So Crystal, whenever you're ready, you can start sharing. And you're just on mute, Crystal. There we go.
Sorry about that. A little bit of a lag still over here. Hi, everyone. Thank you so much for having me. My name's Crystal Barbero. I'm the program specialist at HealthPathways Melbourne. And I've got a background as a registered nurse, so I can assure you I definitely understand the challenges of staying current with the ever-evolving healthcare landscapes. Ensuring that you can swiftly access the right and relevant information is crucial for fostering best practices. I understand that our time is definitely precious and it's the end of the evening and we all wish to log off. So in the limited time we have, our goal is to demonstrate how health pathways can be a game changer, especially enabling you to quickly access the correct information regarding referrals, particularly pertinent with the release of the new statewide referral criteria. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate health pathways to find relevant pathways on management, specifically for hip and knee osteoarthritis. Okay, I've got a bit of a navigation one here, so we'll see how we go. I might have to pause it a little bit, but I just thought this one might be a little bit easier so you can see how the platform works. So this is the main web page. So just visit and log in. Here you can see the homepage with the latest updates and pathway updates. You can search for the relevant pathway by using the table of contents on the left-hand side, or alternatively, using the search bar at the top. Select the pathway that matches your search criteria. Here you can see a clinical editor's note. The clinical editor's note is a brief temporary note that's added by an editor about a development in the wider health system or community that may affect how clinicians assess or manage their patients. It allows a user to quickly find significant information on new or changed information that directly affects local user practice, as can be seen here with the new statewide referral criteria. The background is a brief overview of the core background information with relevant definitions. Further down, we have the assessment section, which is a concise list of steps that users may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway provide supplementary information, such as risk factors, to consider, demonstrated here with typical symptoms and red flags. As we travel further down the page, we'll get to the management section. Here, this is a succinct list of steps that users may consider taking and includes additional information needed to execute these steps and links to further options. As you can see here, referral criteria drop box. Okay, the referral section includes locally relevant requests and referrals that the clinician might request from a third party for their patient. Okay, as shown here. Here we're going to follow the link out to a non-acute orthopedio page. Again, you can see we've got our fantastic clinical editor's note that clearly state the new statewide criteria, all with live links directly leading out to the government websites. Further down, we've got a private section and a public section. And at this point, I'll just stop and just say that the referral criteria Dropbox that you see here is currently being updated, and it will have a Dropbox here that includes all of the statewide criteria inclusion and exclusion information. Hoping for that to go live very, very, very soon. And here you can see locally relevant information. So under Eastern Melbourne, we can there find the Northern Health Fracture Clinic, which provides all of the relevant information for the referral for the GP to use. Returning to the main page there, at the base of the page there, we have our last area, which is our information section, which provides information and pertinent documents for healthcare professionals and for patients. On this slide here, I've just identified the new statewide referral criteria, as you've all covered very well tonight. And it's also got a list of the current pages that we have updating at this present time. And I've just provided an additional list of potentially relevant pathways and referral pages on HealthPathways. This is just our slide to say how you can access. You can go to the website address at melbourne.healthpathways.org.au. It's available to general practice teams and other clinicians within the Eastern Melbourne and Northwestern Melbourne PHN. If you don't have access yet, you can click on the register, which brings up an online form. You can use a QR code and we'll organise access for you. And that's all from me. So thank you very much.
Thank you so much for that, Crystal. Was that it from yourself, Rebecca and Juliette?
Yeah, it is.
Fabulous. I will start sharing my screen again. I thank you all for being a part of tonight's session. It has been an absolute pleasure to have you all here this evening. I hope you've taken away some valuable insight. I also like to extend a special thank you to our exceptional presenters for their fabulous work. By participating in tonight's RACGP accredited activity, you will receive 1 hour in educational activities, and I will lodge those hours through the RACGP on your behalf. At the end of this session, a link to the workshop survey will appear on your screen. Please do take a moment to fill in the event survey for your accreditation and to provide valuable feedback so that we can further improve these education sessions. Your responses are greatly appreciated. Please also take a moment to check out other upcoming infant education events by scanning the QR code on the screen, which it will take you directly to our events page on the infant website, and you'll be able to find out more information on what other education workshops we have coming up and to register yourself for one. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources. You will also receive your certificate within the next 4 weeks of this session from MFIM. I thank you all for your time and attention this evening. That is all from us, and enjoy the rest of your night. Thank you. Thank you all. Good night.